Well, thank you for having me here. It's good to be back in Arizona. It's been a while. I'm going to probably approach this not necessarily from a highly technical standpoint, but from an operative standpoint. I think that the biggest challenge when you think about below the knee and below the ankle disease is still access to care. A lot of these patients get sucked into hospitals where there's different doctors with different algorithms. We've heard already too. That's, everybody treats things a little bit differently. Confusion in goals and teams. And if that patient is lucky enough to come out of the hospital with a preserved limb, maybe after a minor amputation and some vascular work, the reality is it's unclear where they're going, unclear what doctor they need to see, unclear what their medical needs are, and a lot of times they're lost to follow. If they lose that battle, you lost also the ability to manage a contralateral limb that now is gold, and you didn't optimize care. So I think there's a huge necessity and a challenge for these patients that needs to be found. A second huge challenge we have is, and this is a slide, sadly enough, a slide that I think is about 8 years old at this point. Whereas, what are we looking for? What are our objective performance goals when we're managing these patients? They have 3-vessel disease, and then from the ankle down, there's a lot of calcification patterns. And what is that magic threshold? It's not the same. Not everybody needs 3-vessel outflow, and not everybody needs a 6-hour intervention. It's the pattern of disease. It's the wound and the wound care that that patient may get, and the comorbidities and the nutritional status that that patient has. All those things actually allow for you to manage in a more personalized way the care of this patient. Here in the last couple of years, and involved in some of these no-option studies, I've realized how important it is for these patients to have appropriate outpatient care. It's about frailty, it's about understanding a classification from the get-go, a Wi-Fi staging, the conduits you have, what support networks that patient has, how mentally ready is that patient and his family to endure the process of limb preservation, and then understanding what the images is, and what the blood vessels look like, and what the calcium scores are. We've come to this sort of grotesque, I guess, or maybe unpolished, but as close to what we can think based on some of the research and some of the studies we now have, where we create this Wi-Fi against MAC grid. And as you can see, if the MACs are low, meaning the calcification patterns of the pedal vessels are low, these patients probably could do good with both endo and open, being that endo is potentially looking good from the patency standpoint. Of course, the higher the stage, probably the likelihood is you need those patients to have longer patency rates. And so if you do have a single segment greater saphenous vein, that patient probably would be better served with a bypass. As you move to the high MAC scores, I think these patients are underserved by our multiple repetitive interventions, and they should probably start going into the arterialization realm a little bit quicker than before. So it's as much about them, but as much about us. Like, what can we offer? And if we don't have the unbiased approach ourselves, don't think that you should be a superhero. Think that you need other people involved in the team to allow the patient to allow your team to be able to do this, be able to get into a retrograde lateral plantar, or be able to cut down and do a beautiful distal bypass to the posterior tibial. Now, we are just the peak of the iceberg. It's everything that comes behind that's important. I think that the multidisciplinary outpatient group is important. The podiatry, the wound care folks, the vascular technologists that are following these patients, that's what's important. You may direct care, but it's not about them. Now, how can you improve things on the front end? Set yourself for success. Somehow, we got distracted along the way with MRIs and CTAs and all these other awesome things that we have for technology, but at the end of the day, ultrasound is phenomenal, and we can get a lot of information from it, and I think we are not doing a good job or a disservice to the technology, because you can map and characterize disease, you can understand the anatomy of the pedal vessels, you can map the GSV and decide if you have to do something. This is the type of ultrasound that I expect from our group at Hope. And what you get here is you essentially get better than a CTA, because you have hemodynamics all the way down to the pedal anatomy. And then on the right-hand side, you already have a GSV, and I already have a MAC score. So I know if this patient, where is this patient going to fall in my grid, what conduits do I have available, and how can I further improve by understanding what the mechanics are. In this particular case, this patient has an a neuropathic ulcer in the tip of the toe with a normal pedal acceleration time. So even though there's an occluded dorsalis pedis and you may feel very good about yourself because you found it, the reality is this patient doesn't need anything other than good wound care. Measuring that protosystolic thump, meaning the pedal acceleration time, that's essential. If you don't have this, I invite you to try to get trained in it, because what we are learning about the foot is incredible. The foot can be perfectly compensated with just one perineal and two large collaterals to the foot. And you don't have to do any of these like crazy fancy retrograde interventions that a lot of people talk about. I'm not saying you don't need to, and I do perform them when it's absolutely necessary, but we can be much more cautious. More importantly, specifically, I can show you these two patients, which would probably immediately trigger you to do an angiography. Well, the one on the left has actually triphasic flow and has a class 1 PAT. So that pedal acceleration time and the progression of the Doppler signal shows that that patient probably just needs good wound care, and you don't have to throw 30 atherectomy devices and 20 drug-coated balloons at it. It just needs a good podiatrist and a wound care team. And a very interesting paper that was published a while ago is the fact that if you do have a class 1 and 2 post-intervention, then most of those patients go on to do well, meaning if you're able to change the hemodynamics of the foot and go from a very tardus partus to an actually peaky, nice systolic acceleration time, those patients tend to do much better. And don't forget that a simple x-ray that back in the days we were just told this is the Miguel sign, well, it is actually a disease condition, which we now term small arterial disease or SAD disease, based on what Roberto Ferraresi has told us, but this is the patient from the ED, from that x-ray. I already know that this is a shitty candidate for all these bells and whistles that we throw at it. This patient is gonna have high restenosis rates, is not gonna do well, and is probably better served primarily with an arterialization. This is a paper from Roberto showing what the patterns of disease are. You can see on the left-hand side, there's no SAD, moderate SAD, and severe SAD. And then we actually did that on x-rays, and we looked at a lot of our patients. Look at that one on the right with severe SAD and those calcification patterns. Getting into those vessels, you may be able to get a wire all the way down into that dorsalis pedis, and yes, you may be able to put a 125 CSI micro. It ain't gonna help because it's gonna restenose within 3 months, and the patient's gonna be back in your clinic with severe pain. So when you're seeing these calcium patterns, chances are that those patients are gonna require a lot more interventions. As you see on the redo surgical foot reinterventions, these patients with high MAC scores have redo toe amputations, meaning you're gonna cut back, 1, 2, 3 toes, TMA, BKA, and redo revascularizations that you didn't intend to do from the get-go, repeat intervention. So there's a necessity for these patients to get something else, and all of this can be done and can be somewhat identified on the front end if you put a little bit of more effort on the preoperative assessment. Because you can determine based on a multidisciplinary group approach and a good ultrasound, if you medicate, if you operate, if you dilate, deviate, or quite frankly, amputate primarily in a lot of patients, which is a phenomenal also still technique. So back to the question, what are the challenges and options? I'd say awareness is still a huge challenge. We need to improve longitudinal care of patients with an outpatient multidisciplinary care unit that has cohesive inpatient and outpatient services. Back to Dr. Noor's position, we need to have that. Improve preoperative assessment, frailty and pedal hemodynamics, as well as medium calcification measurements. Objective performance goal, novel endpoints, talk about remission, ulcer-free pain days, avoidance of opioids, and there's so many other things that we have to do other than just looking at the TLR and all these things that we have been fixated for so many years. And finally, integration of novel technology and clinical research. Thank you very much.